a nuestros maestros David C. y Michael Stroop, quienes se van a encargar de este segmento, el curso práctico del examen del sistema vestibular y oculomotor. Ya se dio una buena parte introductoria teórica, pero ahora, aunque es un poco demandante hacerlo con tantos asistentes, se tratará de tener una buena interacción demostrativa. ¿Qué más quisiéramos? Que esto fuera un taller hands-on, pero con casi 500 asistentes no es práctico, de manera que muy probablemente va a ser un taller demostrativo.
Okay. So this is going to be a kind of experiment. David and myself try to show you how to examine patients. And we can do that pairwise. So once David is a patient and once me is the patient. And you should also choose a colleague sitting next to you with whom you would like to make the examination. So it should be really a practical tool, hands-on as it is. I always choose pretty ladies, and there are so many, it's very difficult to find, not too many. Okay, David, please, look for someone. Okay. Well, as I said, it's a kind of experiment. And let's imagine this young lady, she's from Russia. She got an acute attack of vertigo and dizziness.
So we just kind of do things in...
How do you start with the examination in the U.S.?
Okay. So the first thing I do, and this is really important, we're going to get it, well, maybe you can sit up on this thing here. First thing I do is measure dynamic visual acuity. Dynamic visual acuity is really, in a way, the most functional test of the vestibular ocular reflex, DVA. We measure visual acuity with the head still, and then we measure visual acuity with the head rotating. And this is typically best done if you have a chart, a Snellen chart on the wall at the end of the examining room. You may not have that, so you may have to use a visual acuity card. So you want the patient's best visual acuity. So if they have contact lenses, that's good. Sometimes with glasses, it's a little hard, but what you want to do is you want to measure the patient's vision with the head still and the head moving. So how would I do that? Let's say she's looking at a visual acuity card. So I'm going to measure visual acuity in both eyes, but this is a test we can usually do with both eyes viewing. So I'll have her read the lowest line on the visual acuity chart. So let's assume she gets down to 20/25 or something like that. Okay, then I will shake the head, and I do it passively. And just as we saw in the earlier demonstration with Michael Stroop, how you cannot follow something like this, but you can follow it like this, we're going to shake the head at about the same high frequency and ask her to keep reading the same line, the best line, and if she can't do it, then you go up and you measure how many lines of visual acuity she will lose. Now, patients like to cheat. They often will stop or start, try and catch a glimpse of the visual acuity card. So you must keep shaking the head, and then you gradually find out what she can do. Then I do it vertically. vertically. So I will have her read the lowest line on the visual acuity chart. So let's assume she gets down to 20/25 or something like that. Okay, then I will shake the head, and I do it passively. And just as we saw in the earlier demonstration with Michael Stroop, how you cannot follow something like this, but you can follow it like this. We're going to shake the head at about the same high frequency and ask her to keep reading the same line, the best line, and if she can't do it, then you go up and you measure how many lines of visual acuity she will lose. Now, patients like to cheat, and they often will stop or try and catch a glimpse of the visual acuity card. So you must keep shaking the head, and then you gradually find out what she can do. Then I do it vertically. finally, I do it in roll, and I'll explain why that is so important. So I find out how many lines she loses horizontally, vertically, and in roll. Now, 2 points. When a patient has a unilateral deficit, like a complete loss of function after a vestibular neuritis, they're going to have more trouble with horizontally than they will vertically. Patients who have bilateral deficits often have more trouble vertically than horizontally. What is trouble? Normal people should lose no or one line of visual acuity in this test. If you've lost all function, you lose 5 lines. 5 lines. So a patient with complete bilateral vestibular loss will lose about 5 lines. Okay. Why did I do this? This is not as challenging a test to the vestibular system because the fovea is still on target. This takes the fovea away, this takes the fovea away, this doesn't. So even if you've lost all your vestibular function, you're not going to lose as much like this. If a patient tells you that this is just as bad, they are making something up. They are embellishing their exam. It doesn't mean they don't have something wrong with them, but this is sort of a test for a functional deficit. So that's how I do dynamic visual acuity.
So I think it's best you do that now pairwise, do the test with a colleague sitting next to you, just to get an idea how to do it. Please, we will take a video of that and post it to Facebook or something, or YouTube.
So take a piece of paper.
Take a piece of paper.
Take the program, which is very...
The program, very good. And do it. So this should be really interactive and dynamic. Here also on the right side, please. We show that on the screen how well you do that. The camera can go to the audience. Can you turn on the light? Most of you, I think, have never done dynamic visual acuity. So the best thing is you use your chart, the back side of the chart, and then you can see if you're still able to read it. Por favor. I don't know how we shall proceed, but we look for the components of the OCR. Vestibular? Q, head tilt. Okay, so something like that. Yeah, I did it too. And, okay.
So have we identified any major pathology in the audience? No.
Okay, and that was a test of the vestibular ocular reflex.
I want to say one point. We do not want to tear the vertebral artery. The vertebral artery is special, so you don't have to, excuse me, huge excursion. The important thing is the frequency and the speed. Same thing with the head impulses. Never do, hurts me just to think about it, never do that. This is very important. And often you might ask the patient first to move their head through the range and make sure they're comfortable. But you don't need to do that.
So keep the head on the front. Okay, then we can move on with the head impulse test. I think this is an additional test for the vestibular ocular reflex, and it makes sense if we, after dynamic visual acuity, move on with the head impulse test. As shown in the anatomy session, you should move the head about 30 degrees downward, so then you specifically examine the horizontal canal, and you should hold the patient's head really tight. This is a kind of a rough test, and you have to warm the patient, and first make sure that the cervical spine is passively well movable, and then the patient normally fixates the examiner's nose, but you can look right into the camera, and then do a very quick turn, just one turn, let's say 10 to 20 degrees. Then go back, do another turn, and look if the eyes stay on the target, or if they move with the head. One turn, then go back. If you do it too quick, it will always be pathological, because then the VOR runs into saturation, so you can make every hit pathological. If you do it with the video oculography, the accelerations are normally lower. Okay, can you do that pairwise?
You must become perfect at this. This is so important. So really do it on each other, and
Okay,
we'll walk around and make sure you're not going to do anything.
We do
really
through
bad.
the rows, and then we check if you do it properly. Okay, please demonstrate it. This is like medical school. Por favor. Take off the glasses. Most often it's
Want me to
better.
test you?
Very good, very good. One movement. One movement. Okay, that's fine, but we just like that. Por favor. He's stiff neck. Good. Señor, por favor. Very good, very good. Señorinas, por favor. Oh, great. Very good. Can you see? Please. Yeah. Yeah, brilliant. Okay. So it's also good to be in the position of the patient. Then you get a feeling for the test. Yeah?
Have you done this already?
Therefore it's good if you change patient, doctor, patient role, because then you get a feeling for the test. Very important. And we are also going to talk about the pitfalls.
You're getting better. So let me make a comment. Can I make a comment? What I see you doing, you're doing too big an excursion. Small excursion, and if you play table tennis or ping pong, you will build strength in your wrists for the head impulse test. So try it on him.
So there are also common pitfalls which you regularly see. One is what David mentioned. I briefly demonstrate pitfalls. One thing is excursion like that. That's much too much. That will not work. So small amplitude will do the job. Small amplitude. Another very frequent mistake is you turn the head and go back directly. This is something you frequently see. Yeah? This is the most frequent mistake. You turn and go back again. So turn the head is just one quick movement. Okay? Tuck, 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 like that. And you should do it in a standard pseudo-randomized way. Like that. Okay? Let's see. Here on the left side. Please, por favor. Very good. And you gentlemen, examine your colleague, please. Very good. Do we have any questions on this test? Any questions? Now is the time, please. Okay. So the question is what you are looking for. Physiologically, the eyes stay on the target. If I turn the head quickly to the left and the eyes move with the head to the left, this indicates a deficit of the left horizontal canal. Okay? Quick movement, the eyes move with the head to the left, patient makes a refixation saccade. So what you're looking at is a refixation saccade, indicating a dynamic deficit of the vestibular ocular reflex. So, can you show how to examine? Now take off the headphones. Okay, perfect. You too, please. Yes, yes. You also see it in acute vestibular lesions. And it's sometimes mixed with a spontaneous nystagmus. But if you do it quickly, you will see it anyway, even in acute vertigo with acute nystagmus. Okay? Further questions? Okay, so to summarize, these are the two basic tests for the vestibular ocular reflex. And you should combine them. Head impulse, dynamic visual acuity. David is still engaged with the ladies. Okay. Again, that was typical mistake, luck. That's not. One movement. Like playing the piano. The note before the normal note. So would you proceed with the cover test? Yeah. Okay. You can have this sophisticated tool or just your hand. So this looks much more professional. Of course, the findings should be the same.
So this will be fun because most people will have a small abnormality on the cover test. So you will get to see what it looks like, but usually in normals it's horizontal. That can be quite normal. What we're looking for in our patients, remember, is skew, a vertical. And there shouldn't be a vertical deviation unless anybody here have a, well, HIPAA, I can't ask private questions, I guess. But if someone has had a fourth nerve palsy in the audience or strabismus, we could probably see some things. But here's how you do it. Now, one other point, it's sort of important to do this looking far and close, if you can do it. So, look at the camera, please. There are two aspects of this test, and the first is simply cover uncover. You look for a movement of the other eye. So the left eye did not move, so she was looking at the target. Now we're going to do the other side and look at the right eye. Look at the camera. Okay, so that's perfectly normal. Both eyes were focused on the camera. No movement, no movement. Now, this is the important one. It's called the alternate cover test. Look at the camera, please. And we're going to do this about 4 or 5 times. Look right at the camera and try not to put this on the eyelashes. Eyes open. She's perfect. Now, but not for long. Look at my nose. See the finding? What happened when I removed the cover? Did the eye move out or in? Pay attention. seem to jump a little bit? Do you have to move your eyes? No? So she has an ESO deviation, because every time it's normal. Every time I move the cover off, the eye went out. Exactly. About 75% of us have exo, and then there's a special group that have ESO, but they're still that can be quite normal. But no vertical. She had no skew, no vertical abnormality. You can do this in 30 seconds. And just look for the shift. And if it's going up and down, you've nailed it. Now you've found a vertical deviation, and that could be a skew, and something has to be evaluated.
Okay, now the cheap German version. Just use your hand, and you can do the same, okay? The less machine, the better. Okay? And what you can provoke in your colleagues sitting to next is a so-called exophoria. The patient goes into convergence. Look here, look here. Cover the eye, 4, 5, 10 seconds, and remove the cover, and then the eye moves inward. So the eye, which does not fixate, getting tired, and moves a little bit outward, and then it moves inward, which is absolutely physiological.
So can we have them do it?
Yes.
And if anybody finds a vertical deviation, I'll give them this thing. All right? So it's out here for you. Find a vertical phoria in the audience. Test each. Don't look at me. You got to start testing.
That's good motivation. Perfect motivation. So you should not be afraid, as an ENT doctor, examining patients' eye movements. Yeah? This can be done by every general practitioner, someone in internal medicine, wherever you like.
So one point, they must fixate. You know, you have to tell it, make sure they're actually trying to look at something. And we have a lovely exophoria right here. Exophoria over here. What else can we find?
Very good. Very good.
So really you should do it with their
Come on.
glasses.
Can you examine him? Then just a look how you examine him. Okay, good. Por favor. Can you examine him? Good, that's enough. Very quickly. All right? So if you didn't see anything, you can do the simple test. I'll show it quickly again. Patient should look at a near target. You cover one eye, and then remove the target. Can you see it? Once again, look here. Open your eyes, please. And now, look here. So this is an exophoria. Look here. And now it moves inward. Okay? So you can do it with a colleague sitting next to you to get an idea how it works. So, any questions on the cover test, the alternating cover test? So, just to point that out, it is really essential to do that. Yes, it worked. He was compliant.
Have we found any vertical deviations yet? I can't believe this is such a normal group of people.
Okay, and as mentioned before, this is one component of the ocular tilt reaction, and another component, which you can quickly see when the patient comes into your office, is a head tilt. What are the two frequent causes of a head tilt? If I come into your office and my head is tilted to the right, I have no cervical spine problem. What are your two differential diagnoses? Ocular tilt reaction, or, David mentioned it, trochlear palsy, fourth nerve palsy. And the head is always tilted toward the healthy side. Yeah? Otherwise, double vision increases.
And I have to say, the bucket test is so useful to separate those two. And it's this is what we use it for a lot. It's very simple. If you have a fourth nerve palsy, the eye is higher, but it's turned out. If you have an ocular tilt reaction, the eye is higher, but it's turned in. So the bucket test tells you right away whether the higher eye is out or in. And you've diagnosed a vestibular ocular problem, right, or a fourth nerve palsy.
So, this is the third component of the ocular tilt reaction, this bucket test, originally described by Fresine from Scandinavia. And we re-evaluated its usefulness, and it's a very, very simple test. And as I mentioned before, maybe someone can translate it into Spanish, the instruction how to build it. Send me an email, I'll send you the scale and the instruction, but not the bucket. Okay? So, it's very simple. So, okay. So, David is looking into the bucket. I turn it to one side, and then he tells me what he or she thinks is vertical, and the normal range is O plus minus 2.5 degrees. So normally it's really 0 degrees. Yeah? You shoot with that 10 times in one and 10 times in the other direction in a pseudo-randomized way. And it's a most sensitive technique to detect an acute unilateral, peripheral or central vestibular lesion. It does not discriminate between peripheral and central. In other words, you got the same findings in a left-sided Wallenberg syndrome and a left-sided vestibular neuritis. But it's sensitive. And it's also important for psychogenic dissonance. If a patient has a constant deviation of 10 degrees, this is less likely psychogenic. If a patient with vestibular neuritis after 2 months still has a deviation of 10 degrees, he or she did not compensate well. So these are the two indications.
This is better than an MRI scan.
And much cheaper, and much quicker.
Much cheaper.
And you can use it in the emergency room. So we have plenty of these buckets in our hospital. And it's so easy. Okay, so the fourth component is clinically not relevant. What comes next?
Should we do a quick eye movement?
Head shaking outside.
Okay, so there are a number of provocative tests. I should have brought, did you bring your vibrator?
No. This is you. David told me. This is what he always tells. If he's on a lonely island, the only examination tool he takes with him is his vibrator to determine vestibular deficit.
I'll show you a picture of a variety of types of vibrator that could be used to stimulate the vestibular system in the afternoon, just before dinner. So, provocative tests. And there are a number of them. And which ones are really the most useful? It's head-shaking induced nystagmus, probably at the top. We're not talking about positional nystagmus, of course. So let's talk about head-shaking nystagmus, and I'll tell you how I do that. Let me give you a preview about what you might expect. If you have a unilateral peripheral lesion, and you shake the head and stop, which way is the post-head shaking nystagmus going to be? Is the slow phase going to be toward the bad ear or toward the good ear? Who votes for toward the bad ear? Okay, who votes toward the good ear? Okay, and do all the other people think there's going to be no head shaking nystagmus? The bottom line is, it's going to be slow phase toward the bad ear, just like the spontaneous nystagmus. So that's what you get with a typical unilateral peripheral lesion. Now, what do you get with a central lesion when you shake the head? What can you get? Vertical nystagmus. If you get a differently directed nystagmus from the plane of head rotation, that has a name. It's called perverted nystagmus, and it is often a clue to a central lesion. There are a few other clues with head shaking. If the head shaking produces a nystagmus that's opposite the direction of the spontaneous nystagmus, central. If the head shaking produces a nystagmus which quickly changes direction, goes into reversal phase, central. But what you really want to do is find those patients with a unilateral vestibular loss, and they'll never compensate for the head impulse in the head impulse test. They'll never really compensate for head shaking induced nystagmus, and they'll never compensate for vibration-induced nystagmus. Even when all the spontaneous nystagmus is gone, you can still use those three tests to pick up unilateral loss. And that's very important, because now you have a reason for the patient being in your office. So let's do those. So, Frenzels, eliminating fixation, very important. And, you know, I call this the Romberg sign of the vestibular-ocular reflex. This is the Romberg sign of vestibulospinal reflex. And historically, Romberg was a great German neurologist who wrote the first textbook of neurology. And of course, he described the Romberg sign in syphilis, those patients who had posterior column loss. So here's how I do it. You can either you do it or have the patient do it. Probably doesn't make much difference for the head shaking test. And I tend to do it myself so I can control the head a little bit better. Here's how I do it.
With a glove?
Always with the Frenzels to eliminate fixation. First, I have the patient. Can you move your head right and left first? Yeah. Are you comfortable? Is it okay with that? Right. I wonder how she's going to feel at the end of today. Don't know. Probably it's most sensitive if you put the head down just a little bit, because it puts the lateral canal on the plane of your shaking. That's it. So, 15 seconds, pretty high frequency. Keep the chin down just a little bit. Stop. Look for the nystagmus. If it's peripheral, unilateral, labyrinthine, it's going to be a slow phase toward the paretic ear. If it's central, it may be vertical, wrong direction compared to the spontaneous nystagmus, or a quick reversal.
So, now it's all yours.
Be careful.
Shake the head of your colleague.
I've only had one person ever complain about me examining them, and it was a lawyer, of course, after head shaking when he developed a little
can you do
bit
that
of
quickly?
thing like
How
that.
many do you do? 10, 15,
So
20?
about 15.
15.
And you have, unfortunately, you have to do it kind of fast.
15 turns.
But just
Please.
like the head impulse test, keep the amplitude down, just like that. Are you doing all right?
You did? No. Later. You can. Okay. I have plenty. No, close your eyes. What about eyes open, eyes closed? I don't know. Normally I have them closed. Yes, it's more convenient. Yeah. The question came up about open or closed eyes. There's an agreement between the US and Europe. Close the eyes of the patient. More convenient. Doing good job. Senor. Okay, this looks really good. There are a lot of colleagues with strong arms and strong hands who manage that properly. So head shaking nystagmus. Later on we are going to show some videos on that. It's very helpful to detect a unilateral vestibular deficit, and the nystagmus looks like the prior spontaneous nystagmus, and the mechanism is well explained, asymmetrical charging. Okay. Now, eye movement. Eye position, eye movement. Yeah, that's good. Thanks.
Okay. As far as the vibration, I have a really good video that shows that response, and I'll show that a little bit later today. The next thing which I tend to do is I do a Valsalva maneuver. And there are a couple reasons. So we already saw one of the main reasons where you might want to elicit a nystagmus with a Valsalva maneuver, and that's with a fistula, superior canal dehiscence in particular. And the patient takes a deep breath, and that's a Valsalva against a closed glottis, which changes the spinal fluid pressure, pushes things out. And then you do it again, nose pinch Valsalva, which puts the pressure into the ear, and the nystagmus is in the opposite direction. It's a beautiful test. And does anybody know what other neurological problem gives you Valsalva-induced nystagmus? Craniocervical junction abnormalities. The Chiari malformation. You've increased intracranial pressure, and they get vertigo, nystagmus, headache, and pain in the shoulders. So, and it's simple. With Frenzels, you have to do this with Frenzels or against a closed glottis. Okay, so maybe we saw an eye movement exam earlier. I'll do a quick one again. And this is just sort of how I do it. We've done alignment first. We already did that. So this is a general quick eye movement exam. So first fixation, straight ahead, looking for a spontaneous nystagmus.
By the way, what is a spontaneous nystagmus? How is it defined? What is a spontaneous nystagmus? What's the definition? Very trivial, but not all doctors are aware of it. Spontaneous nystagmus. Does it say something about peripheral or central? No. It's a nystagmus which occurs when the patient is looking straight ahead. That's a spontaneous nystagmus. So a peripheral vestibular spontaneous nystagmus is a spontaneous nystagmus, and a central fixation nystagmus is also a spontaneous nystagmus.
Okay, then we're going to just look for holding gaze. So look here, please. Keep your head still. Look out at the pen.
So that's a typical mistake. The patient moves the head with the eye movement. And there's one simple procedure which you can do. The patient holds his or her head with the hands, and you have stable conditions. The same happens during the sakha.
That's good. How do you tell whether nystagmus on eccentric gaze is pathological or physiological? Many of us will have a little bit of nystagmus when we look far out to the side. If it goes away after 2 or 3 beats, it's probably normal. If you move the pen in a little bit or your finger and it goes away, in other words, it's only there when you're very eccentric, it's probably normal. I tend to use, when the patient can see it with both eyes, then if it's still there, it's pathological. The only problem with that test, it depends on the size of your nose,
Yes.
the bridge of the nose. So if you have a, your nose is out here, it's not a good test.
So there's no general agreement about the terminology of endpoint nystagmus.
Right.
So, but I totally agree with David, and I'm very pleased to hear that. So if you see it, if a patient is still fixating with both eyes, then it's most likely pathological. In Asia, of course, it's more difficult for the people because of their small nose bridge. They can look further to the right and to the left.
So I have them look up, and then look down here, looking for nystagmus. One other little clinical pearl, if you will.
Out and down.
That's where you may pick up some downbeat nystagmus early. So out and down. So we've checked for nystagmus very, very quickly. Now the next thing, and we only have really 3 other things to do. We've got saccades, pursuit, and virgins. So let's do saccades first. She shows absolutely normal features. When she goes out, she often makes a little secondary saccade, but when she comes back to center, it's usually 1 saccade. So we're a little bit hypo when we go out normally, and when we come back to center, we're normal. You may even see a little bit of overshoot. You know, all of us have a cerebellar disorder. It's just varying degrees. There's a little bit of cerebellar dysmetria in all of us to some degree. So the real problem is, when is it pathological? But this is perfectly normal behavior. The other time, by the way, where you see dysmetria normals is from top to straight ahead. A little downward overshoot is just normal in many, but it goes away after you do it a few times. So let's try that. Ever so slight overshoot when she goes down. That's just normal. So those are saccades. The only other thing I do, especially to look for things like intranuclear ophthalmoplegia or Parkinson's disease. So the eyes are moving together. One is not lagging. They're fast. They're promptly generated, quite normal. Next thing is pursuit. The mistake we usually make is to go too fast. And most of us are going to have a little trouble with that. So we want to go slowly. So that's really pretty good. You know, if you just take someone off the street and ask them to do this with the head still, which is a totally unnatural behavior. We almost always track with our eyes and head. They may not be that good. So you have to, not get too excited about minimal food pursuit deficits. Vertically, though, like many normals, she shows a few little saccades when she goes downward below the midline, but that's all normal. She also really anticipates. I'm up here and she's already going way ahead. You look ahead in life, don't you? Yeah. Okay. So that's a pursuit. probably a little better ways to do this, like put something long on their head. She's perfect at that. So we're asking her to cancel her reflex. It's a measure of smooth pursuit, basically. We heard about canvas this morning. You want to explain to them what canvas should show?
I have a patient on that.
Okay. All right, so that's vergence. Vergence is simple. So that's quite good. If they have a little trouble with that, you may give them a slowly moving target. And if all else fails, the best vergence target is money. A 2,000 peso bill, or a 100 euro bill, or a 20. It used to be a $10 bill in our country, but now it's a $20 bill. Inflation influences the vestibular exam. One little small point. Look at the camera. Close your eyes and keep looking, and open. Close and open. The reason I'm doing this is patients who have infarcts, strokes in pica, Wallenberg syndrome, when they close their eyes, they'll go way over to the side. So a tonic deviation of the eyes under closed lids really is a hallmark feature of Wallenberg's, along with other things. And then you've already done the vestibular stuff.
Okay, I think you should do that now step by step. I think there's no order which is given.
But make up an order in your mind and do it the same way in everybody.
Yes.
You
should learn it also mechanically, that you do it in every patient in the same way. So what would you recommend to start with?
So
Eye movement, eye position we had, and then gaze evoke dissections?
we did gaze.
Yeah, how do you start?
So how do we do it?
Yeah, maybe you present the whole examination.
Do the whole thing?
Yeah.
Quickly,
and then
Okay.
the audience can repeat it.
Good afternoon. How's your insurance? Do the whole exam. It's like doing Shakespeare in 90 minutes. They have a special theater in London where you see all of Shakespeare in 90 minutes.
So these are the vertical canals. That's it. So 1 minute and 30. So it's very easy, and maybe you remember this or that piece. You can examine the colleague sitting next to you in the same way, please. So we need 3, 4, 5 minutes. So make up your mind. I can show you a slide with all the steps of examination, which may make it a little bit easier. Can we switch to the slides, please? So here you see most of the parts David was presenting. So maybe we can do that in a similar way. First look at the head position, then look at the eye position, then look at the nystagmus. You can examine the saccades, It's a hypo or hypermetric, conjugate or disconjugate as an internuclear ophthalmoplegia. Smooth pursuit, smooth or saccadic. Then look for a gaze-evoked nystagmus. Optokinetic nystagmus is also a nice test. I'll show you an example. It's important in children and in patients who are not very compliant, and also good to identify psychogenic blindness. Then the head impulse test, visual fixation suppression of the VOR, and subjective visual vertigo. So, would you like to examine the colleague sitting next to you? Having an idea by these slides, and then try to do it. And we will go through the rows and look if you do it properly. If you have any questions, now is the moment to ask the question. Please. Now, questions on the examination. What about the schedule? Are you behind? Yeah, can you examine? Okay. Can you examine the colleague sitting next to you? Please, por favor. Practical course. Head impulse. Okay. Okay. Normally you don't have to do that. So it's very simple. It's very difficult to interpret. Now we test the left anterior, right posterior. Right anterior, left posterior. It's very difficult. The horizontal canal is enough.
Excuse me, one person asked me about optokinetic nystagmus, which Michael mentioned, and those are the reasons. If you don't have a tape or a drum, you can use your fingers. You just have them count your fingers as they go by. That's a poor person's optokinetic tape.
Okay, like that, with your fingers. For the optokinetic.
You have to count the fingers.
Okay, but this is
Well, this looks religious up here. Any questions? Yeah. They're on the iPhone. And the iPhone is better because So look at this, optokinetic nystagmus on the iPhone. Gracias.
What is leading is this symptom of the patient. Okay? Okay. We are all aware of the limitations of a practical course with so many people. I know this is very difficult. Normally, you have groups of 20, 30 people for a seminar or a bedside examination, but with such a huge group, it's really difficult. Therefore, I would recommend we just move on. I know we can do the positioning maneuvers very quickly. I'm looking for a volunteer. What about you? So, independent of the patient history, you always have to do the positioning maneuvers. So please be seated here, take off your glasses. And sometimes patients just complain of dizziness. No, you can sit down here. So, put on the examination glasses. If you don't know which side is affected, always start with the right side because this is more frequently affected. Turn the patient's head 45 degrees to the left, and then her right posterior canal is in the plane of your movement. And just move her down, and look if you see a nystagmus. If you don't see anything, you should wait 1 minute. Sometimes there are patients who develop positioning nystagmus with a certain latency. You can shake the patient's head. Sometimes you provoke that. If you don't see anything, the patient should sit up. Can you move down here? Mind your glasses. Okay. And then examine the left side. What do you do if the patient history is compatible with the BPPV, but you don't see anything? How do you proceed? Patient should learn how to do the diagnostic maneuvers by him or herself, and then do them the next 10 days in the morning. If there's nothing, she does not have a BPPV. If there's something, she should call the doctor. Which side is affected? So turn the head this way. Now this one is in this area, and then that's it. Okay? For horizontal canal, the patient should lie down. And this is now quite ideal. Okay? Put on the glasses. By the way, you will also see a horizontal canal BPPV if you examine for posterior canal. This is frequently. And then the patient should turn the head to one side. You would expect a linear horizontal nystagmus. If it's a canalolithiasis, it's beating downward, more intense on the affected side. If it's cupulolithiasis, it's beating upward, more intense on the non-affected side. And then the other way around here. And that's it. Okay. And the final step is stance and gait with the already mentioned Romberg. Can you stand up? Okay. And this, you can do it without shoes, normally without shoes. And there are, no, it's okay. You start first with an easy task, and then it's becoming more and more difficult. This is what the neurologists normally do. Romberg did not describe that, so that's the regular way normally. So stand like that, please. Hold your arms like that. Close your eyes. Why do you open and close the eyes? Because thereby you can better identify a sensory deficit. Okay. And then open your eyes. Both legs together. Close your eyes. Open your eyes. Now the tandem Romberg, one foot in front of the other. Close your eyes. Okay, so patient with bilateral would have problems like that. Okay. And the next step is standing on one leg. Open your eyes. You stand on one leg. First with the eyes open. Then close your eyes. 1, 2, 3. That's because of her shoes. I'm pretty sure. So, normal patient, this is my experience, standing on one leg with the eyes closed for 5 seconds would indicate a good balance. And the next step to escalate that is standing on one leg with the eyes closed and the head tilted backwards. This is even more difficult. So, and what do you do in patients in whom you expect a psychogenic disorder of stance and gait? Distract them, counting 100 minus 7. Okay, and finally, examine how the patient walks, like on a catwalk. Can you walk up and down, please? You look how the patient is moving the arms, if he or she is going broad-based or like her. And please turn around. Okay, and now walk on an imagined line, heel to toe, with the eyes open, and then with the eyes closed. Okay, so examination of stance and gait, I think, is very important. You can often easily make a diagnosis. For instance, if a patient walks like that, what do we expect? Parkinson's. And patients with normal pressure hydrocephalus, they walk in a similar way, but they move their arms. This gives them the rhythm for walking. Hemiparesis, gait ataxia. So it's often you get an idea when the patient comes into your office about the diagnosis. So it's really helpful. Therefore, the patient should walk into your office. You should have a look at him or her when he or she comes in. Then you have a first idea. Is it psychogenic? Is it organic? Is it normal? It's an extrapyramidal disorder and all this stuff. Okay. Any questions on that? If this is not the case, Ricardo.
Bien.
Muchas gracias.
Por favor, un aplauso muy merecido a esta parte práctica extraordinaria. Muchas gracias. Bueno, amigos, ahora les invitamos a una muy buena comida que les tenemos preparados. Por favor, pasen al salón comedor. Muy buen provecho. Nos vemos, la comida es de 1 hora. Por favor, consideren que a las 14:50 en punto estamos iniciando una de las mejores formas de aprender las modalidades que son las perlas clínicas o los casos clínicos. Gracias.